The next session, which is rational use of antibiotics in common respiratory infection. The moderator is Dr. Subramanya NK. The lead discussant is Dr. Ritubroto Kundu. And the panelists are Dr. Chetan Trivedi, Dr. Sonia Bhatt, Dr. Vinay Kumar S. and Dr. Shomo Shekhar AR. So Dr. Subramanya needs no introduction in the respiratory chapter. He is the Medical Superintendent and Professor of Pediatrics, PES, Institute of Medical Sciences and Research, Kuppam. He was the past chairperson, Secretary, IAP National Respiratory Chapter and Vice President, IAP South Zone 2022. Dr. Ritubroto Kundu, he needs no introduction here. He is the Professor of Pediatrics, Institute of Child Health, Kolkata, and immensely popular in the infectious disease arena. Dr. Chetan Trivedi, he is a consultant pediatrician in Neha Children's Hospital, Ahmedabad. And he is also a very prominent figure in the area of infectious diseases and pulmonology. Dr. Sonia Bhatt, she is the Professor and Head, Department of Pediatrics, FH Medical College, Agra. And Dr. Vinay Kumar S. He is an Associate Professor, SS Institute of Medical Sciences and Research Center, Davangere, Karnataka.
So let's not waste any time, we'll go straight away to the cases. I want all of you to clap for the wonderful organizers of this conference. Flawless conference. I am congratulating them on behalf of all the faculties. Being the past president of the chapter, they have, matched like, it's like Virat Kohli's century, there are no words for their amount of commitments, day and night work they have done. And so all of you need not thank the organizers for inviting everything, all those are not required. So we can straight away start with the case now. The case number 1, all the cases are correct even if the answer is incorrect or correct. So I have kept only those cases which are borderline, dilemmas, and both answers will be correct. So therefore please be careful, and I want the audience opinion as well. These are not textbook descriptions. These are real life situations, what happens to us in practice in pitfalls. For whether to give antibiotics or not is the crux of the question. I want audience to react first. Now 8 months old baby with colds from 2 days and fever, brought with excessive crying. Somebody told you do otoscopy. Otoscopy is not possible, there is wax on both sides. Now we are stuck. Now audience, will you give antibiotics? Yes, please raise your hands. No. And what will you do? Breastfeed the baby, it's crying. Only give paracetamol, okay. No, don't give antibiotics. What about antibiotics? Who will take up? Somsekhar, will you give antibiotics?
See, first of all, this baby has got some clue that maybe some ear-related issues going on. Think of it, otitis media.
Okay.
Look for other causes, important. When it is 8 months baby, look for other causes.
Other causes of cry?
Cry.
Okay.
Maybe rashes to other things.
Okay.
And important, otoscopy if possible only. Try to look into. Otherwise, 8 months may be difficult. If it is partially open, just try to see the membrane intact, bulging, all those things. Here, 6 months baby, if it is 6 months baby, I would have started antibiotic. I will not ask.
No, my question is, what is your diagnosis?
8 months acute otitis media.
Empirically?
Yes.
Okay, fine.
Yeah, because there is all clues goes in favor of otitis media. But there is no fever. Need not be. But try to do the examination.
Okay.
But your question is of antibiotics.
Tricky. Now Kundu sir wants to take it. No problem. Let us have a debate. No fever but more cry.
No, you cannot come to a conclusion. There is a small caveat in this, that the baby had respiratory symptoms for last 2 days, colds. So usually otitis media can be preceded by a little bit of cough and cold. But there are 100 other causes why a child without fever will come with inconsolable crying. Starting from the central nervous system, the child might have a raised intercalating tension. A foreign body might be inside his eyes. He might, even as a boy child, he might have a testicular torsion.
Sir, you will go for all the other. No, I got a point. You will go for all the causes of cry. But what I want to know from the audience side, I will ask all of you, what is cry and what is excessive cry?
One thing I want to tell you, if the child is less than 6 months, because at the age of less than 6 months, the chances of an otitis media landing up into a central nervous system infection is very high.
Okay.
In those cases, I would definitely give an antibiotic. Then I'll try to clear the wax, examine the eardrums. If they are bulged, if they are swollen, if they are red, then I'll continue antibiotics. If they are not, I'll try to find some other cures. I might do an LP and other things I'll do.
Sir,
but as the child is above 6 months, I would like to wait, give some anti-pain medicine, clear the ear and try to examine the drums. This is my take.
Okay. Somsekhar, back to you. In which situations in acute otitis media you will give antibiotics, where you will not give antibiotics?
See, as I
That
said,
clarity has to come to audience. Do you agree?
yes,
Yeah.
6 months we should give.
Less than
Whatever
6
the
months you
diagnosis
should
is,
give. Okay,
I
then?
give. 6 months to 2 years. See, here we can wait for 2 days. Just
Okay.
see for a, what is it, if the pathology develops further. You give, if it is fever, if it is uncontrollable cry, persistent fever, or not response to previously, you had same issues previously. That is the time. But in this case, 8 months, 2 days wait. If it is persistent,
Okay,
symptom,
by
I
age,
prefer to
by
give.
bilaterality and by
bilateral.
severity,
Bilateral.
we will decide whether
Yeah.
to give or not to give antibiotics. Chetan, you want to add anything?
It's the same. Age, laterality and severity. These here are the factors to decide whether to give it for
Okay,
the
one
antibiotics
small
or not.
question. Now there is a wax. You want to refer to an ENT surgeon and then take a call, or you will take the call?
We should
try
take
to
a call because we should try it once again, maybe after removal of the wax. But I think we should do it. Otoscopy is our domain as such. We have to start learning it and you have to practice
Excellent point. I think for just otoscopy, we should not refer to an ENT surgeon. Will any one of you have removed the wax in the OPD?
Where?
One more important thing, you should look at the other clues. Supposing a child comes with an ear pain with unilateral conjunctivitis,
Okay.
then it's a highly suggestive of non-typable Haemophilus influenzae you are dealing
Excellent
with.
point.
That case will definitely need antibiotics, not only amoxicillin, you have to add clavulanic
Clavulanic
acid also. So you have to look for the other clues. You cannot give a blanket statement, if it is less than 6 months, give this, if it is above this. So you have to search, look, and then decide whether you want to give antibiotics or not.
Kundu sir, now you raised a valid point. Let me get the questions clear for the audience. When you will choose amoxicillin and when you will choose amoxiclav, number one. Number two, when you will give 50 milligram per kg, when you will give 90 milligram per kg. You all agree with me? Yes, please
so
answer.
There are three
Usually
bugs,
Moraxella we should think.
three
Not only the
important, three
influenza.
important bacteria which causes otitis media. Heading the list, pneumococcus, followed by H. flu, third is Moraxia catarrhalis. Of this, H. flu and Moraxia catarrhalis has developed resistance to penicillin by elaborating an enzyme known as beta-lactamase. Whereas pneumococcus has been resistant to penicillin by altering the pneumococcal penicillin binding proteins.
Protein, okay.
For the last two, that is Haemophilus influenzae and Moraxia, you have to add clavulanic
Fair
acid
enough.
to destroy the beta-lactamase.
Okay.
And for those pneumococcus which have an MIC between 2 to 4, we increase double the dose of amoxicillin.
That's fine.
And those above 4, amoxicillin will never act. Then you have to go for ceftriaxone. So
What-
this is a series how you look at.
So in our country, we'll still go ahead with 45 to 50 milligram
yes,
per kilo.
because as rightly told, for the non-meningeal isolates of pneumococcus, still the penicillin resistance in our country is not that high. So we can afford to give a
Okay,
trial of
fair
50
enough.
milligram per kg. If not improved within 24 to 48 hours, then you think of increasing the dose.
You want to add something?
Yeah, sir, but sir, I think we'll have to revise the dose sooner or later because lots of literature is coming that resistance is increasing because recent studies from KIMS Bangalore and St. John's in 2017, they're showing that increased resistance is up to 17 to 20%. They've already
So
documented.
in Agra, you want to give 19?
No, not
Kolkata,
now,
you
sir,
want to
not
give
now.
50?
We may have to. I'm just telling because
That's a good
increased,
literature.
If
as
it
Dr.
doesn't improve
Subramanya,
within a day or two, the dictum is like that, start
3
with
days.
50 milligram, wait for 48 hours,
48 hours.
no improvement, then you escalate.
Okay.
If it is improved, then
Then we
continue
continue
there
the
for
same
full 10
Fair
days.
enough. I think, did we get a clarity on when the child has an excessive cry and if you can do otoscopy? Fair. If you can't do otoscopy also, don't get worried. You can give amoxicillin and clav in when you suspect Moraxella. 45 to 50 milligram per kilo is enough in most of the circumstances in our country. Do otoscopy well. Differentiate between a cry and a troublesome excessive cry. Most of the children with cold and nose block will cry in the night. Every parent's sleep is disturbed. Parental disturbance is not considered as excessive cry. Really, if the child has cry which is not consolable by feeding and palliative measures like giving paracetamol and pain relieving measures, you have to go. Don't meddle with wax. I think these are simple messages from case 1. I don't have more time. I'll go to case 2.
7 to 10 days.
Okay, fair enough. The antibiotics has to be not given for 3 days or 4 days. It has to be given for fairly quite lengthy period of time. Now, case number 2, 10-month-old baby with moderate VSD choked, and there was aspiration and distress on admission. Vitals improved now. The patient is admitted, chest X-ray is normal, child is feeding well, and normal findings are there. Will you give or will you not give antibiotics? Audience first. How many will give antibiotics? Hey, all of you are sitting with the thing that today is the rational day and you don't want to give antibiotics. I don't know. Nobody is raising the hands. Is it because 4 o'clock and you don't want to raise the hands, or you don't really want to prescribe an antibiotic? Fair enough. I think who will
Low
take
threshold for antibiotic.
No, Vinay, you want to take? He's been quiet for some time. We'll give it to Vinay.
This is either there are 2 possibilities after aspiration. One is aspiration pneumonitis and aspiration pneumonia. Aspiration pneumonia will take time to develop because of our organisms has to grow and start developing pneumonia. So this child, since it is improved immediately after stabilization, it is unlikely to be a pneumonia. I will wait for 2 days. If child starts developing fever and becomes sick and develops respiratory distress, I will consider it as aspiration pneumonia. Or else if child doesn't worsen, it gets improved, I will just without antibiotic.
Excellent point. I think you should clap for him. If there is aspiration pneumonitis, chemical inflammation, you need not give antibiotics. You can observe in a hospitalized child. Otherwise, if it develops pneumonia, you will know by the findings, resurgence of fever, worsening, so on and so forth, you will give antibiotic. That is one. If it develops pneumonia, which antibiotic you will give?
So we have to cover anaerobic organisms. So
there is no term like pneumonitis. TK, only aspiration.
No. There is no pneumonitis. No, it is a chemical injury to the lungs. It is a chemical injury to the lungs mainly because of the stomach acidity.
So there is no term like pneumonitis.
We call it a chemical injury to the lungs because of the
Okay, sir, let us not get into controversies related to terminologies that we can go on discussing. They have to give me extra 5 minutes for that. Now the question is that for you, if it develops aspiration pneumonia, and which antibiotics you would give?
So I would like to cover anaerobic organisms, so I will give amoxiclav.
You will give amoxiclav?
Yes, sir.
Will you give penicillin, crystalline penicillin?
Yes, sir. Crystalline penicillin, gentamicin.
Kundu sir, now we know anaerobes and
first of all, let me make a point very clear. Crystalline penicillin at least is not available in Calcutta.
Okay, fine.
I don't know whether it is available over there. We don't give crystalline penicillin these days. Most important point, what rightly have been pointed out, he wants to give coverage of anaerobes. If it is a hospitalized child, I'd like to give cover against Staphylococcus, Pseudomonas and anaerobes.
Upfront.
It is a hospital. Now there is a very important point. This child is not an ordinary child. He is a moderate VSD. So he is a compromised child. For a compromised child, your threshold of giving antibiotics should be low because his lungs are target. He cannot inflate a target lung properly.
Enough. The point taken.
So here you cannot see it like other. Had it been a normal child who has aspirated.
So to cut it short for want of time, the threshold is low and the threshold for escalation is also low.
In this case, I will admit the child and I might give an antibiotic also to start with. Then I will wait for 2 days. If the respiratory rate increases, his saturation comes down, his X-ray shows after 2 days some abnormality, then I will continue the antibiotics. If it doesn't happen, then I will stop the antibiotics.
Okay, I'll go to the next case.
But here I will start with because he is a compromised child.
Fair enough. I'll go to the next case. Sonia, you have been quiet. You can take it up. 3 months old baby has...
It will be over by 40 minutes.
No, Sonia. 3 months old baby with cold 2 days back, now brought to OPD with mild respiratory distress. SpO2 is 92%. Feeding well, comes from a village of 40 kilometers. They can't come back for worsening. They decided to admit. Now, having admitted the patient, will you give antibiotics or no? They can't stay in your hospital for all your experiments like I will wait and watch for 3 days. That means you should not bill the patient for 2 days and all these issues are there. Now how will you handle?
So okay, sir, this is a 3-month-old child who has a history of cold 2 days back and mild respiratory distress. SpO2 is 92%. Definitely he warrants admission. But as there is no fever, which gives me a doubt that it is unlikely to be pneumonia, though there are two features like hypoxemia and increased work of breathing is definitely there. So my answer would be, again, if they are ready for admission, he is admitted with me, I'll wait for the
No, what is your
antibiotics.
diagnosis? Let's come to the
The
diagnosis.
first diagnosis will be bronchiolitis.
Bronchiolitis.
Yeah.
Okay. Now, my question to Chetan and then to Ritabrata. Some patients appear as bronchiolitis on admission, but somehow they get converted into pneumonia. Do you all agree? One second, sir, please hold on for a while. No, my question is, with both within inverted commas. Converted means they start developing fever after admission?
See,
No, one second, let them comment, yes.
so bronchiolitis-like picture is what is it? There is a respiratory distress, there is low-grade fever, child is having some tachypnea. So this is what, and coughing, the child is coming with a bronchiolitis-like picture. Now to get it converted to pneumonia, it's like either there is a grunting is there, fever is there, and if you find something localized feature, then it's pneumonia. So it's not like bronchiolitis like the picture which is getting converted, because of pneumonia it is in developing phase. Maybe.
Sir, give the message for the audience clearly.
Bronchiolitis has a very clear picture. First of all, the child will start with sneezing, little bit of running nose.
That's right.
Then the child will start coughing. But as days go on, this cough will become respiratory distress. Whereas vis-a-vis a pneumococcal pneumonia develops very suddenly. If you do an X-ray, if you find a large consolidation, a huge amount of fluid accumulated in the pleural space, CRP very high, the child is very severe distress within a very short span of time, then my diagnosis will be pneumonia.
Yes.
Okay.
But if it follows the pattern, little bit of running nose to start with, little bit of fever, followed by cough, followed by distress, then my diagnosis is bronchiolitis. Then I won't give antibiotics, I'll wait, all I need to do is give bronchodilators and see the improvement.
Fair
And
enough. Sonia, you want to add
bronchiolitis usually
anything?
will be playful child. It won't be a toxic looking child.
Fair enough. Sonia, want to add anything?
Yeah, so that's what. So anyways, I'm admitting this child with 92% saturation is warrants. So I would like to observe for some time. And
So fair
then only
enough,
I would
I
like
think-
Again,
to
it's a
add
low
in.
threshold for
I was trying to
antibiotic.
probe them if they wanted to start antibiotics, so they don't want to start antibiotic until and unless there are clear-cut evidence of community-acquired pneumonia.
Pneumonia in this
Fair enough. Now, 6-year-old child has come with cough of 20 days duration and low-grade documented fever. Now, let's not beat around the bush like on and off fever. There is fever. There is no weight loss. Chest X-ray is normal. Will you give or not give antibiotics, and which antibiotic, if at all you wanted to give? Audience, will you give antibiotics? Yes, okay, Bapre. No. And how many don't want to give antibiotics? So some of you don't want to give antibiotics. Bapre.
Not at all.
Now there is a divided house. Who will take it up?
Sir,
Chetan, you want to take up?
Yes.
Okay, take it up.
Because sir, first of all, this 6 years old child having cough since 20 days. So what is our diagnosis first? That is important, because what is the type of cough, whether it is a wet cough, it is a paroxysmal cough, it's a dry cough, whether there is an allergic tendency, whether family history is there or not. And so prolonged cough, which really requires antibiotics, only two conditions. Either it is a pertussoid cough, pertussis we are keeping in mind, or if it's tuberculosis. Like these two they require some antibiotics. Otherwise, it may be allergic, it may be cough which is coming, irritating cough. So first we have to reach to diagnose which kind of cough it is, family history is there or not.
Okay, I'll give wet cough.
It's a wet cough. Then another indication for antibiotic, that is PBB will come.
will be
So wet cough is typical, which is lasting
PBB
more than
4
15
weeks.
days.
So wet dry doesn't make any sense. A cough might be appear to someone wet, to other it might appear dry. So it doesn't matter. A non-sick child with a low-grade fever, old enough, above 5 years, comes with cough. There is no hurry in giving antibiotics. I'll investigate and then give
What
antibiotics.
investigation?
First of all, I'd like to do an X-ray chest because
Normal.
It's normal.
X-ray is normal.
CBC
Then
is
I'll do-
5600, ESR is 40. I will go on telling you,
we don't
polymorphs,
give that-
none of them have helped us in life.
So, no, antibiotics are not needed. You give some antitussive and wait and see what might be the other.
How long you
reasons
will
for
wait?
cough. We can wait for 5-7 days, then give. There's no hurry in giving antibiotics.
Subra, but this one doesn't look like viral. I prefer to give
Okay,
antibiotic
let me
course
ask-
and see the response.
I'll ask
And,
Vinay.
as per the guidelines of NTP, I'll give the
What is
spelling.
NTP guidelines?
It just says which doesn't comes in the way of
Cough for more than 2 weeks,
I'll just give
Unremitting
it
cough for
after
more than 2
weeks.
weeks.
2 weeks,
Give it
low-grade
trial and-
fever. What will you
Documented
give?
fever. So amoxicillin for
Amoxicillin.
2 weeks. That's
So
and
now
ex-
RNTCP says,
and
Sir,
weight loss.
unexplained fever
Sir, low grade fever is 90, okay, 100.
100.
कितना देना है सर को दे देते हैं 100.
It's not fever, sir, more than 100.4.
No, this is.
Okay,
this
sir, there
no
is fever. There is fever. There is fever. No, there is fever. CRP is
Sir, we don't-
कितना देना है? 6. See, the problem is that don't ask these investigations. What is the antibiotics? Unfortunately, I think I'm not criticizing anyone, but antibiotics should not be decided by any of the investigations. They have either helped us or not helped us, like coalition government, some political party, sometimes supporting, sometimes not supporting. So therefore, do not believe or don't overtrust the investigations. Kundu sir, you will agree. Please come back to that concept of NTEP algorithm and the role of amoxicillin.
The NTP
Yes.
algorithm says another very important thing. You do an X-ray. If the X-ray is suggestive, highly suggestive of TB, you go for it.
Oh, fine.
The X-ray is not suggestive of TB, but the child has persistent cough or persistent fever, then you give. But there is something abnormal in the X-ray, but it is not suggestive of
X-ray
TB.
is normal.
So even weight
X-ray
loss is a
normal.
criteria, which here there is no weight loss.
NTP in
Third
that
criteria is weight.
situation does not say to give anti-TB drugs. If the X-ray is normal, the child is suffering from persistent fever or cough, you investigate for tuberculosis in some other place other than lungs.
Sir, I want to just ask, drag in Bala sir. Sir, wet cough of 2 weeks, will you give or will you not give antibiotics?
No. First of all, unfortunately, in our algorithm for tuberculosis, cough has found a place. Most pediatric TB
You don't get cough.
do not present with cough.
Sir, now there is
Very
cough,
rare.
let us say.
The presentation with cough and low-grade fever as TB is very, very rare.
Okay, Rawat sir, please, go ahead, no issue.
Subbu sir, acute viral bronchitis is the commonest cause of wet cough. And acute viral infection can last for 2 to 3 weeks.
Okay.
Only if it is beyond 4 weeks, you think of PBB and a bacterial cause.
Okay.
So, viral bronchitis is the commonest cause of wet cough. Please
It is
be
a
very clear.
bronchitis. In
You
a
don't take an
6-year-old
antibiotic and
child,
all.
it is a bronchitis, and bronchitis, rightly pointed out, will take at least 4 weeks time to come down.
Fair.
No matter whatever you give.
Fair enough.
So don't give antibiotics
The
here.
point is very clear from all the experts that if there is no parenchymal involvement, which is fairly ruled out by an X-ray, otherwise it would have appeared over 2 weeks. See, normal chest X-ray may not rule out pneumonia or parenchymal infections, but after 20 days, if you have a normal chest X-ray, I think it is fair enough to wait. Dr. Kundu was very much correct, but you will also do CBNAT, whatever, blah, blah, to be done. That's fine, fair enough. Let us close about the decision about taking antibiotics. Now I have very less time. I'll go to case number 5. 6-month-old baby, very, very precious, NICU graduate, all stormy course, whatever, high HFNC, CPAP, BPAP, whatever you want, everything is done. With a horrible course, it got discharged with huge bills. Now cold and respiratory distress for 2 days is on bottle feeds. Parents want to admit because this is the child which they have conceived after 10 years and hospitalized. Now tell me, will you or will you not give antibiotics? But audience, please kindly tell me what you have done really, not what you want to do in the conference. In conferences, nobody wants to give antibiotics because there is no way you can give antibiotics in this hall. But in your nursing homes, you will always give. But my question is, nahi, Rawat sab, thoda hold kijiye. I am taking into confidence, it's not for the front row, okay, unless I ask. Okay. Now the question is, please tell me, will you give antibiotics or have you given antibiotics? Please raise your hands. Don't tell me no. And now they have given the antibiotics. Excellent. Now let us come to some consensus today. Vinay, you want to take? Vinay, take it up.
Although this baby looks like a bronchiolitis, we have to think that this has so many high risk factors for pneumonia. Like this child is bottle fed, which is an independent risk factor for development of pneumonia. And it's a low birth weight and had a stormy neonatal course where lungs are compromised. I won't say upfront no, but I will have very low threshold to start. Right. However, definitely I will investigate this child because this is.
So you have a low threshold for giving antibiotics. The reason is?
Child has a high risk for
child
development
is
of
started with cold.
Two important reasons what he has told. Number 1 is bottle fed. That is a high risk factor for pneumonia. Number 2, it's a compromised child because he's a NICU graduate. He will have a bronchopulmonary dysplasia. So they are very prone to infection.
That is one part. The patient is hospitalized. Now do you want to observe as bronchiolitis or you want to upfront start antibiotics?
If you are hospitalized, we can observe.
If it is hospitalized, we
Yes,
can
we can
observe.
observe, yeah.
Somshekhar, you want to observe or give antibiotics?
Closely observe and
Closely
have eye
observe.
throat
Okay, he wants to
because
go
this is a
closer and
malnourished
observe.
baby.
Fair enough. Now, Chetan, you want to observe from
Malnourished baby
distance?
this is.
Yeah, we have to observe only.
You're going to observe,
They
Sonia?
doesn't want.
I won't observe. I will give antibiotic and then observe.
Oh, wow.
Because he's a precious child. Precious child.
Sir, most of the time this can be RSV, bronchiolitis.
I would give and then decide.
Okay, now there is 4:1. Anybody wants, he can come in.
This child is also looks like a bronchiolitis.
There is no evidence of BPD because child had been normal previously. So you cannot have BPD in a child who is normal and now he is getting symptoms.
Sir, leave alone the BPD. Will you give antibiotics or not?
If he is underlying compromised lung, I'll give, but there is no evidence of compromised
Agreed.
lung.
I'm
Yes,
coming
So
to the
there is
point
no
of when
indication of
you give.
antibiotic in this
Yes,
child.
yes.
No indication. Absolutely, it is a plain case of bronchiolitis.
One important thing.
No need.
He's respiratory distress for last 2 days.
2 days
Child-
only.
Child
He had
is suffering
cold. He had
respiratory
cold.
distress for
He had
2
cold.
days.
He was normal previously. Cold and distress, bottle feeding, nothing to do. Low blood pressure, nothing to do. He is a child with typical bronchiolitis. Please don't give antibiotic. Wait, you are not in a hurry. He'll not die within 24 hours.
Had it been a normal child coming any 6 months old, but this case is something different. Your
Sir,
threshold should be very low.
Bottle
Excellent
feeding
point.
and
I think, shall I close it? We will give the verdict. See, the point is, Kundu sir, with due regards to all your knowledge and everybody's expertise and experience, let us analyze what is the issue. If somebody is VVIP for various reasons, it could be precious baby, Prime Minister's grandchild, whatever. The question is, the organisms are not going to listen to all these things. So either there is a bacterial infection or there is no bacterial infection, independent of all these factors. All of you agree? So your decision should be based on the science and scientific evidence, and tell me, if somebody gives birth to one child every year, does it become non-precious? No. So therefore every child is precious to us, and therefore we have to go scientifically. I think, Kundu sir, if you want to give antibiotics, refer them to Bangalore. We will manage without antibiotics.
Sir, you want
No,
to...
any other, please sir, come in. No
we
issue.
want to ask something more.
Yes, sir.
Because in this scenario, I may be asking whether the child is taking normal feeds. Even though it is bottle feeds, he is accepting, playing. You have to go all these things. Just by putting this, deciding antibiotics.
Excellent point.
One
I
may
think
be
we should
right,
clap
one may
for
be-
sir. We need
Because-
details.
Because
we
we
should
have to
not
go the other
upfront tell
details.
whether yes,
Just
no.
because of VIP, I
Point
think
taken.
even VIP are much more knowledgeable than us.
Yes,
if
sir.
you start antibiotic, they will question you. This doctor is starting all the antibiotics. like
Antibiotics.
that.
The point taken.
So the best thing is you ask for the history, how the child is playing, whether he is taking feeding, or even the mothers are best. Whether your baby is normal, yes, my baby is normal.
Excellent
If they
point.
like that, you can go away, wait for some more days.
Excellent, sir. Now, for want of time, I am going to the next case. 5-year-old clinically, provisionally, I am just cutting short the story, clinically looking like community acquired pneumonia for all practical, blah, blah, story of 5 days fever, this, that, everything you add in the slide. The evaluation ended up with the diagnosis of atypical pneumonia. Let us not, I am making it short. Now, will you want to start upfront with macrolides? Sonia, Vinay, Somu, Chetan, any one of you can take. You want to start upfront monotherapy with
So
macrolides?
how,
the
how did
syndrome
you
appears
confirm
like-
that it is atypical
No,
pneumonia?
syndrome appears like typical atypical pneumonia.
So we are not sure that it is atypical. Are we sure that it is atypical?
Clinically sure.
Clinically sure, matlab, are you sure about that bug?
No bug,
Then
nothing.
if we are
Whatever you want.
not, so that's what I want
Walking pneumonia,
to. So if
breathing
we are not
pneumonia,
very
everything
sure
is there.
about that bug, then we should take care of other bugs also, which are common at this age.
Excellent point.
So that's why I would like to give ceftriaxone. Suppose this patient I
So
am
the
admitting.
question answer is no monotherapy with
No.
no monotherapy
Because
with macrolides.
see, azithromycin, if you add macrolide, that is not going to cover the other organisms which are common at this age, say streptococcus pneumonia and staphylococcus.
So you will add macrolides?
I will add, if I suspect it, I will add the macrolide. The other will continue ceftriaxone or that for other
Kundu
bugs.
sir, I will complicate the 1 second, sir.
Yes,
I'll complicate the question for you. Will you add on day 1 or will you add on day 3, day 4?
There are certain pointers which will tell you that this is a high chance of mycoplasma pneumonia. First of all, age above 3 years, school-going child. Number 2, it's a walking pneumonia usually they have. Their X-ray findings does not matches with the clinical findings. Number 3, does the child has any other evidences in the form of skin rash. Erythema multiforme is very common. Does the child has Coombs positive anemia? That is also common. Does the child have arthritis? So if these things are there, you can be fairly sure that it is a mycoplasma pneumonia, and if you do a respi PCR, this will come out as mycoplasma pneumonia. It takes only few hours time for the report.
Fair enough.
Then you start with macrolides up front. But if you are not sure, then you start with amoxicillin. I would give a combination of amoxicillin plus macrolide if these things are there, but I don't have a respiratory PCR or any other evidences, then I'll give that.
So even respiratory PCR throat swab is taken, that is not going to be getting a correct thing about what a mycoplasma pneumonia.
Got it. Now Sonia, will you give amoxicillin or comoxiclav? Anyway, you are going to add macrolide later. But
I will start with amoxicillin only.
amoxicillin only. Yes, very good.
Response, I would add on azithro.
Okay.
It's not.
Now this rapid fire is for the audience, but it will go back to the panelist. If there is cold as the presentation, will you give antibiotics? All of you are liars. Now the question is, in colds only, when you will give antibiotics? Exceptional situations in cold, running nose, but you will be forced to give antibiotics.
Cold is running nose, you are telling? Cold and running nose. What is that cold?
Cold is running nose.
Running nose is watery nose?
Watery.
No. If it is a thick, purulent discharge,
thick,
when thick purulent, then if you are suspecting sinusitis, that is like, persistent, worsening,
So when colds
severe.
will become sinusitis?
So there is a role of antibiotics. So sinusitis, if you are putting a different diagnosis, in case of cold, then it becomes,
So I think Chetan has a point that prolonged colds more than expected for a typical viral
Or if there is a worsening of URI, like after 7 to 10 days, it was resolving, it comes back with headache, with facial pain, sinusitis will add on.
So next question, audience, for cough, will you give antibiotics? Everybody says no. But now tell me, in which coughs you will give antibiotics? One is pertussis. Sir, aap idhar aiye. Anybody from panelist, in which situations of cough will you give antibiotics?
Persistent cough more than 10 days.
Wet cough more than?
Yeah, persistent cough, developing fever.
Okay.
Then we'll give. Otherwise, for initial few days.
A cough with high-grade fever with respiratory distress where we are suspecting a parenchymal thing like pneumonias.
Cough in a patient with pre-existing diseases like bronchiectasis,
cystic
fibrosis, etc., etc. I think
so as such, for cough itself, we are not going to give antibiotic.
Okay.
So we are going to get some diagnosis along with the cough, what is happening, and then we decide whether it is pneumonia, we'll give antibiotic.
Okay.
If we suspect PBV, we will give antibiotic. If we suspect pertussis, we'll give. Okay. We suspect cox, we'll give. So that is the reason we give antibiotics,
So
not
you
the
don't,
cough.
I think the point is excellent. You don't give antibiotics for cough. You will decide to give or not to give for the cause of the cough. What has caused the cough, whether it is justified or not justified. Now, wheeze, will you give antibiotics? No, very loud. Now, in which wheeze you may give which exceptional? Wheeze because of mycoplasmal pneumonia.
Even sir, if it's a monophonic wheeze and we are suspecting foreign body there, it might require.
Okay, she has raised a new controversy.
Many foreign bodies does cause lot of infections.
No, I'm very happy when something new comes. A foreign body is there.
Lodge, yes, sir. It causes.
Vijay Shekaran, sir, you have removed so many foreign bodies. Will you give antibiotics?
Not necessarily to give antibiotics. The first priority is to make
antibiotics
arrangements
does
for removing the foreign body. If you know that or you suspect, you send a proper place to remove the foreign body.
Sir, I will complicate.
Don't suppress the cough.
Sir, I will complicate the case for you. Foreign body 2 days back. Now the child has come to you in respiratory. Will you give or will
not
not?
upfront.
No, you should not give because cough syrups and antibiotics is not.
Fair enough. Okay. Now, okay.
But once, yeah, sir.
Okay. No, with pneumonia it's different. I'm telling uncomplicated, just aspiration. Okay, next question is respiratory distress is there. Will you give or will you not give antibiotics? Please be honest. Loudly I want answer from audience. Yeah, I'm asking for the symptom because they give for symptoms. That's the point. The idea is how irrational we have become is because for every symptom we are deciding whether to give or not to give antibiotics. Audience, do you all agree? Cold, no antibiotics. Distress means give antibiotics. This is some kind of shell or locked-in syndrome or cocooning that we have made for ourselves. Now, audience loudly, for leukocytosis, will you give antibiotics? No. Okay, very good. Excellent point. So, cause of leukocytosis should decide the antibiotics, not leukocytosis. Excellent. Chest X-ray suggestive but not clinically evident.
Maybe previous X-ray result.
It has been taken outside, sir. We have not taken. It has come with X-ray. Sir.
So we
X-ray
won't treat
reported.
the X-ray, we shield the patient.
Excellent point.
The patient,
So, therefore, we will not give antibiotics. Agreed. Sometimes the radiological abnormalities take 6 weeks, 3 weeks, 4 weeks to resolve, while clinically the patient might have improved. So, I am coming to the point when this topic was given to us, rational antibiotic therapy in common practice. Every panel I have attended in the past conferences, they were telling, don't give antibiotics, don't give antibiotics, don't give antibiotics. And all the audience used to listen to the discussions. They used to go to banquet and have a nice banquet, and next they used to write antibiotics. Because in banquet you will forget whatever that has been taught from our. Therefore, efforts have been done, and what we decided was that we will tell when to give antibiotics rather than telling when not to give antibiotics. So that was the way in which we took this discussion forward, so that in other conditions other than the context that we have told you, or the thinking process that you have developed in these 6 or 7 cases should make you very, very judgmental, and you should have either up or lower threshold for giving antibiotics and take a wise call clinically, not based on expensive, unwanted investigations. That was the message, and lot of things have been done, and I am coming to the end. Just give me 2 seconds of time. We prescribe and then think, what is the diagnosis? The problem is we should make a diagnosis and then prescribe. The rationality will be there in place. There are lots of ways in which we can kill. The best example is Israel-Hamas war. Many good and bad are killed. We are stressed, therefore we write antibiotics. We think that we can cure with antibiotics. We are happy prescribing than not prescribing. There are many other reasons why we write antibiotics. And there is no awareness regarding antibiotics also, which one to give, which one not to give. And none of us will prescribe, but the chemist will prescribe the antibiotic. And someone else, or the parents themselves buy the antibiotic. So therefore, it is a very, very difficult battle on stewardship that we are going through. Last, there is rapid fire for the audience. Injectables, those of you who wants to say yes, raise your hands. Injectable antibiotics are better than oral. Please raise your hands if you say yes. So injectables are not better than oral. Oh my God. Committee level, no. Okay, my God. Okay. Costlier the antibiotic better? Newer the antibiotic better? Known antibiotic better? Known angel than unknown devil? Okay. When in doubt, give antibiotics? We don't have doubts. Antibiotics reduce the severity and fasten the recovery in all infections? Not bacterial, yes, viral, no. Okay. Prescriptions will prevent secondary bacterial infections? Okay. Babies less than 3 months require antibiotics? Not all the time. Rawat is disagreeing. I have to complete the antibiotic course, even if I have started irrationally. Somebody has started. No, this question was asked, Kundu sir, bear with me for this joke. When I was asking in every conference, how long you will take antibiotics? How many doctors have completed 5 days of antibiotics? Please raise your hands. That's the first question. And many have not raised their hands because they have taken the antibiotics not for 5 days of their treatment which they wanted. They take the antibiotics as long as the representative sample lasts. Once it is over, they don't buy antibiotics. Increased CRP and counts require antibiotics. URTI does not require antibiotic always? Is it so? Some URTIs also require antibiotics, we have to choose them. LRTI requires antibiotics? Not all. Normal chest X-ray does not require antibiotics. Okay. Community acquired pneumonia can be viral, but we give antibiotics. In pneumonia, death is due to bacteria or hypoxia. Can be because of both, but even bacteria cause ultimately hypoxia and death. So hypoxia is the killer. Amoxicillin is as good as amoxicillin. Okay. Commensal organisms are always friends. It depends on the host. Okay, fantastic. I can relax if I have given antibiotic. No. Okay. Now lastly, let me tell you, I should not confuse you. Sir, itna confused kar diya, but tell us when to give antibiotics, when not to give antibiotics. I will just request the frontline academicians just to close your ears and listen to these nonsense words from me for 1 minute. The reason is, I am oversimplifying the indications for giving antibiotics. Tuck in your day-to-day practice tomorrow. If you are in the main roads like nose, throat, larynx, trachea, bronchi, bronchioles, highway, most of the diseases are viral. You don't need antibiotics. If you go to sideways, use trachea tube, middle ear, sinuses, these are sideways, and dead end alveoli. What happens is, there is stasis of secretions and there is bacterial growth. Am I simple? I have made it simple for you. So these are the situations when you need antibiotic. Even tonsils, if it is organism on the surface of the tonsils, won't cause problem. If it gets into the crypts, there is micro abscesses that are formed. I am closing. So therefore you need antibiotics. Lastly, if you are confused, please become member of the chapter. You will get clarity on whether to give antibiotics or not. And there is a logo here. It is only 2,500. It is going to rise very sharply by next year. Please become member today only. Thanks all of you for excellent participation, and clap for the panelists who have not been told any answers. So please clap for all of them, and thank you very much.